Good morning, my dear students. I am Dr. Sabarinath Ravichandran. I am a consultant pulmonologist. I finished my MD, MRCP, Diplomate in European Respiratory Society, on the way to DNB Respiratory Medicine. So these are my qualifications. I am an assistant professor in the Department of Pulmonology, Balaji Medical College Hospital. I am also a consultant pulmonologist at Rela Hospitals, Krompet. I am also having my own clinic, and I am also a faculty coordinator in Speed Institute, Chennai. Right. So, for an introduction, our IMA, MSN Tamil Nadu wing, they had created a very good initiative of going to different experts of different fields and taking their best feedback and forming it as a video and giving to the students as a crisp nutshell. Wow, what a great initiative. Really, hats off. So this is how the student should be active, okay, in order to learn. So now I am in the field of pulmonology, okay. For an undergraduate, they asked me to treat to the undergraduates. So undergraduates will be having reading my subject in the final year in a part of medicine called as pulmonology, because medicine is like a sea. We have got respiratory in that, we have got cardiology in that, nephrology in that, gastroenterology, neurology, rheumatology, dermatology, it goes on. So in that, the respiratory is one of your long case or a short case which will be kept in your exams in your undergraduates. So they wanted me to cover that respiratory part in a nutshell, what an examiner will ask and what the examiner will expect from you people. It was a very great initiative really. So to give a nutshell about the topics of which we are going to discuss, we will be discussing different cases, different life scenarios. I will be sharing my experiences in different cases. Meantime, I'll keep in mind that you are undergraduates and what you need to know regarding that case. Okay, sir, why you need to concentrate on these clinicals? Everything is available in books. That is what the mistake happening now, my friends. What is happening is that nowadays, because of the advancement in the investigations, because of the advancement in the lab, what has happened is, when a case comes with abdomen pain, all are rushing to all kinds of investigation. Okay, they used to do an CBC, RFT, LFT, ultrasound abdomen, chest X-ray, MRI, CT, whatever investigation is available, we do all. And finally, we treat the reports. Okay, now see, an anemia is there. Come on, treat anemia. Oh, see, come on, and low sugar is there. Let's treat the low sugar. Oh, see, there is an ultrasound, some cyst is there. Let's see what it is. But the patient will say, sir, I'm having pain here, and you're treating for my cyst which is located somewhere away. So this is what the scenario happening. Nobody is listening to the patient's symptoms. Nobody is listening to the patient's signs. Nobody is watching the clinical signs properly. This is my straightforward, bold remark on the upcoming generations. Even my generation, many doctors are like that. It's not so. The art of clinical medicine, before the invention of these investigations and advancement, the art of clinical medicines was very great. Now, directly we are doing a 2D echo scan to see what kind of valvular relation it is. But just think, before the invention of the echo machine, I remember my professors of medicines and professors of cardiology who are now, what to say, gone. Many of them are not now. Many of them have passed away and many of them have left the practice. They just used to keep the stethoscope and just say, oh, this is an MS with MR and AS with AR. Oh, this is an MS with VSD present. And they will even say this much should be the ejection fraction. When we do the echo and confirm, it will be same. How are they able to diagnose just with the stethoscope? And we people are not able to. There only I found that our art of clinical medicine is dying. That's not so. The art of clinical medicine should never die. We should not send the patient for investigation. You yourself think, doing 1,000 investigations, 100 investigations, and then finding a positive point and treating it, is it right? Or you yourself taking the full history and examination and coming to a proper differential diagnosis and doing one investigation which is going to confirm your diagnosis, who is called a doctor? I think the second case is called as a doctor, not the first case. But what the generation now is doing is to investigate all and treat the reports. Very sorry. Just think how much the patient will spend for it. 100 investigations, 20,000 for investigations, gone. But before, what they used to do? Just 200 rupees or 300 rupees consultation fees, one investigation to confirm some 500 rupees, and total burden of 20,000 is reduced to 1,000 rupees. So think in lot ways. Why I want to give you this as an intro means, here I am not only going to speak about just pulmonology. I want to motivate you people what clinical medicine is all about, what clinics is all about. I am a pulmonologist, I totally agree, but I am a very good physician too. That is very important. So you people all have to know how to handle the cases very perfectly. Don't go for unnecessary investigations. Be very precise. For that you need a proper clinical sound knowledge, in which all these many books are not going to help you. These books are secondary. Seeing the patient, analyzing the symptoms, listening the signs. 1,000 times I have heard the murmur of MS. 1,000 times I have heard wheeze. Lakh times I would have heard the fine end inspiratory interpretations found in ILD. So I found that is totally, this is ILD, this is Velcro Krebs. This is how it goes. We don't need a CT scan to diagnose ILD. By proper symptoms, signs, we can diagnose it as ILD. This knowledge should be attained to each and every doctor present here. This is since Tamil Nadu, everybody in Tamil Nadu should be perfect. Be whether you are government college or private college, no problem. But be very precise in clinical medicine. So with this small intro, don't think that I am very harsh to you people or I am talking and everything. I am just advising. Because we are the new generations, new upcoming doctors. Our old doctors are going away and we are the new ones to blossom. When we are the new ones to blossom, we should be the ultimate, we should be legends. We should be same like that generation. I am not against the investigations, I am towards it, but only to confirm, not to do all. Okay, so this is the motto, and once again I congratulate IMA-MSN for this initiative and also for asking me to cover the topics on clinical medicine. I think in the upcoming classes, I think there will be live video sessions and they have given me a schedule to what all to cover. They asked me to cover about different pulmonology topics. So we will be doing it in the near future, don't worry. So apart from this, the things which we are going to discuss, even there is my personal YouTube channels, there are my personal Instagram channels where I post daily hundreds of x-rays. There is my personal textbook of respiratory medicine where each and every point in clinical respiratory I have dealt. I have dealt with 100 professors, different professors across India and got the points of pulmonology, and that is how is me. So similarly, you people should catch 100 professors like me and form your own concepts. That is important. Please, I beg you all, don't let the clinical medicine down. Please lift the clinical medicine. In this corona curfew, you will not be able to see the patients sitting at home. Please. So when you come back to the hospitals, touch the patient, feel the patient, get the concepts right, and then go to your books and make it as a thorough concept of your own concept, and we are gonna rock. Meet you soon, guys.